right, thank you so much for staying with the Monday Report Town Hall session. We're still having this conversation on people who use drugs and HIV, the correlation and the silver bullet to enhance this intervention. Trevor Mbija at Citizen TV Kenya, 2242 is the SMS line. I see a lot of your feedback here. I'll be posing them to my panelists here in just a bit. But Taib Abdulrahman, you work with the Reach Out community service provision. What do you think is the lasting solution to this issue that we're talking about? Because I know you interact with them a lot. What are the gaps and what are the possible solutions? Yeah.
Number one, as my colleague has mentioned, we need the structural intervention, that is the law,
yes.
the enabling environment. We really need to look into how we can be able to facilitate an enabling environment, because there is a very thin line in part of using and also incarceration or crime using. In terms of using drugs. So first thing is to be able to create that enabling environment, having a very good law, which is human right based, which is talking to the people, which is bringing people to services than getting them away from services. Second is the involvement of civil society organization. We really need to have the tech in terms of how best can we be able to give them space in terms of facilitating, doing the treatment, in terms of assessment, clinical interview, and also how best can we be able to have support for funding so that they can be able to move around and make sure that we scale up on services, because we've been doing pilots for many years, but now we don't want to do pilot anymore. We need to have the evidence-based intervention in action so that we can be able to reach out to more people, engage people into services, and also linking them to different opportunities. Third thing is we have done the business plan for people who use drugs in the Mombasa County. We really appreciate the leadership of our governor, Hassan Ali Joe, who has supported us to be able to have these centers, to be able to support. So we need the political will, the political goodwill. We have Abdul Somar Sharif Nasser, the Member of Parliament in Vita, who has been very supportive. He talked about needle and syringe program before we started the program. It was, for him, it was a blow. He wanted to go into politics, and this program came in 2012 before coming into vying for the MP. So this shows that we have people within the coastal region in Mombasa who are passionate. So if we can have those goodwill and continue to have the continuous support, we'll be able to have or deal with this situation. And also we need to have the treatment centers, availability of it, because we need to have a comprehensive hub. Mombasa County have been in the forefront to be able to support us in terms of opportunity for medically assisted therapy, needle and syringe program, through our partners, Kenya Red Cross, who have supported us through the Global Fund, to be able to reach out. I think it was a taboo to mention needle and syringe, and people will ask, why do we give needle and syringe? And people are doubting, because this is an evidence base. Because 10 years back, when you talk about this, people were hiding out in terms of sharing, in terms of giving the needle to each one of them, and it's an efficient way of HIV transmission. If I use a needle, an infected one, and share with you, Trevor, definitely the probability of having HIV will be higher than the person who is using a clean needle and syringe. So we really need to have the comprehensive package for harm reduction as one bullet. We need to have multicultural approach that has been talked here, so that we can involve people who use drugs at the ground level to be able to have their voices, to be able to be listened in terms of program, in terms of management, and also planning to this.
But Abdul Rahman, what is the best intervention measure, especially for community integration? Because there are still some that have a culture where they think drug abuse is a curse, or it is something that is in the family. How do you deal with that, and how do you integrate these people back into the society?
One, because harm reduction is an evidence-based intervention. It has packages, which one of them is community outreach, or involving the community that you're working into. So we really need to have a continuous information and knowledge sharing to our community. I know, even in our family, when I started this work, it was like, how do you engage people to use drugs? How you will be encouraging people to use, but the vis-a-vis of that is we're encouraging them to go out into program, to join into program, to have, and the best way to link is to have community meetings, to engage the community level within the chief barazas, within the community level engagement that we are as civil society society organization and also community-based organization to be involved to have that. Family intervention is key because we have missed out for many years. We have not involved families in our discussion. We have not brought in their voices to be able to see how best, because they're affected. They're affected big time, and they really need counseling, they need support, they need to be engaged into the processes that we are doing.
Okay. Dr. Kate, are there specific intervention or specific programs that you think works for this particular group of people? And should we rethink our strategy?
Thank you, Trevor. Under the National AIDS and STI Control Program, I said within the 9 counties, we have specific clinics that address and attend to the people who inject drugs.
Yeah.
For example, as Dr. Shikeri was highlighting, and my colleague Hussein, and then even from the representative from the mayor, we have clinics whereby people who inject drugs go in and are able to be assisted, medically assisted, go through a medical assisted therapy, and able to attain methadone for free. And in fact, most of the clinics per day, they attend to more than 1,000. As I said, we have under more than 8,000 clients in the country who access methadone every day, which is still a restricted drug because of abuse. It can be abused. And not only that, when they go to the clinics, they're able to access HIV services, tuberculosis services, and as well as the needle syringe program, rehabilitation as well, back to society, that community outreach to see how do you rehabilitate these clients to ensure that they stop taking the drugs and are able to continue their life. Because most of them, remember the number that we highlighted before, is young people. In fact, the youngest which had been enrolled into the MAT clinics was around 16 years old and 78 years old.
Yeah.
When you look at the society, it's a society problem. And more so, I know the coastal area is one that is really more affected. And out of the numbers that we have been enrolling over and over in the clinics, has made us that in Lamu County, which is the latest entrant in establishing a MAT clinic, because of the high numbers that we have. In fact, within 2 weeks, we had enrolled, I think, more than 100 of them. And so when they come in, not only do they access the clinical part, but the psychosocial part, being reconciled back to the society, that psychosocial support to the community as well, and the law enforcement coming in that this person is willing maybe to change their behavior and then be integrated back to the society other than charging them.
Okay.
And many, for example, in the MAT clinics, more than the one, because of that therapy, it has reduced 40% of criminal and petty issues in the country.
Yeah.
And many have been even reconciled to their families because of that. And I think you featured one of the cases of we have young people who have graduated, who are initiated to, for example, heroin, which is very addictive. And they have lost not only their livelihood, their families as well. So these clinics, which are free, funded by the government, but as well as PEPFAR and Global Fund, they have come in very, very handy.
Yeah.
But these are not the only 9 counties that are affected in the country. There are many others.
Okay.
And we hope into the future that we'll be able to establish them. For example, in Busia and Isiolo, because of the transit, we have noted that we need to establish clinics in those areas. But it's a big problem in the country that I think we need to address it, but look at it more comprehensively and look at it holistic. How do we rehabilitate our people?
Yeah.
Thank you.
And Agnes, from the law enforcement perspective, we know that the law enforcement agencies, including the judiciary and the police as well, play a very crucial role in dismantling the supply of the drugs. But what role can they play in reducing the demand, in demand reduction, instead of just dismantling that supply and bundling people into prison?
Yes. The law enforcement is mandated to ensure there's no supply within the country. But now it boils down now to the principle of supply and demand.
Yeah.
When we work on the harm reduction programs, and we actually encourage our law enforcers to ensure that we support the user.
Yeah.
And we encourage for actually rehabilitation. And these people are actually reintegrated back into the society. And they are no longer users. So the demand is no longer there. And that is one way of ensuring that the supply is no longer there.
Yeah.
Yes. So that is why we are supporting the programs. These are programs we've been implementing very closely with NASCOP.
Yeah.
And actually we've reached out to various law enforcers, that is within the National Police Service and Prisons Department, and of course the judiciary. Because when you look at the law and actually the clients, before they actually get into the judiciary, they are clients of the police first. Mm-hmm. The police are actually the arresters.
Yeah.
So in as much as they are also supported at the judiciary level and at the prisons level, the police is actually the entry point.
Yeah.
And at the same time, the police is also the entry point in actually dealing with the supply of drugs.
Yeah.
So it's been actually a milestone for us. And like my colleague has mentioned, wherever there is a MAT clinic, there is that low level of petty crime reduction. Mm-hmm. And when there is a reduction, it clearly shows that drug usage is reducing.
Okay.
So by the end of the day, it shows that the supply will also decrease.
Okay. Dr. Dija, let me hear from you in terms of the interventions from the coastal region. If someone is watching you right now and they're wondering that they're dealing with maybe drug abuse here and there, where should they start from? Where should they go? Where would you guide them to?
Thank you very much, Trevor. We usually work with the CSOs, the CBOs, Reach Out and MEWA. So if somebody comes to us directly, we usually counsel them and then take them back to CSOs. Yeah. There we have to test them and look at what types of drugs they use. They will be counseled and they will be checked whether they are ready to really get into the program. Yeah. And they will be checked on HIV, TB, and they'll be taken through an array of tests.
Yeah.
So they don't just come. It's not like you have flu and you come in and I give you a prescription. No, it's quite a tedious process, but the CSOs are the ones. We do not go out. The CSOs are the ones who bring the patients to us, the clients.
But then again, reintegration to the society, because some of these people who are dealing with substance and drug abuse, after they've somehow recovered, the society is still shunning them because some people believe it is a curse, others believe it is witchcraft. What are the specific interventions that the county has put in place so that they don't go back to the same desperate situation that they were in before they started drug abuse? Because now they're clean. True. Is there a job that they can get, even if it's in the county level? What are the programs you have for them?
In fact, most of the clients that are stable with us now, they ask you, Daktari Sasa, what are we going to do? Do you have a job for me? Yeah. They actually are ready to go and work. But it's really unfortunate that there are many institutions that would not give them a job. So through His Excellency the Governor and with partners like UNODC and of course the national government, we've come up with a sustainable business plan. I think you know the donors are going away and we are in a journey towards self-sustainability. And this business plan, we are going to use it as a tool to take to private philanthropists and private institutions in Mombasa. So we're looking at PPP, public-private partnership. Yeah. And we're telling them in our tool, this business plan, sustainability business plan, that we want them to give them jobs, to be friendly to people who are actually recovering or have recovered from drug abuse, and also skills, apprenticeship programs, skills building, trainings, and all that. But we're also we're saying this is a part of the domestic financing. Yeah. The other one is we're telling the partners, again, PPP, to be working with us to get mobile dispensing, mobile treatment centers. Yeah. So that, right now with COVID epidemic, which has Kate has said, 1,000 clients a day is not a joke.
Yeah.
I mean, how are we going to meet all of them?
Yeah.
And also, stick to the COVID protocols and all. So we've increased number of methadone centers, but they're not enough. We really need to look at mobile dispensing.
Okay.
And the other one is also, I feel the UHC really must integrate or must have a component for people who use drugs.
Okay.
It is missing right now. I think they are part of this community. Thank you very much.
Right. And Dr. Ruth, that's actually where I wanted us to go to. Challenges of sustainability and domestic financing. What are the gaps and what are the possible intervention measures? Because you just mentioned that the numbers are colossal and the donors are also leaving.
Thank you very much, Trevor. And I think one of the beauty about the medically assisted therapy program is that how it started. We first started this program by visiting other countries.
Yeah.
A delegation including the governor of Mombasa, governor of Kwale went with us, and we visited a number of countries. The last country we visited was Mauritius. And we looked at all those aspects. And one of the aspects we are asking ourselves is that, are we going to be able to maintain and sustain this program? First of all, it was the whole discussion of what is the consequences of not acting at that point. And by then, drug use and people inject drugs had become a crisis. You remember the days of when the U.S. ambassador then took this issue to Parliament, and we had the shortage of heroin, and we had all those challenges that we got.
Yeah.
So we went there not only to just learn about the program, but to see what is going to be unique about our program. So moving forward, when we initiated this program, one of the things we did was to look at how do we get the government resources to fund the drugs itself, the therapy itself. So that we've achieved so far. The drugs we are using, the methadone itself, it is purchased through exchequer funds. So that is the beginning of sustainability. And as you know that this country just recently faced the whole issue of now what happens when donors are moving out, including the field of ARVs. So with this particular program, we've started well. Now the next level and the next phase we must begin asking ourselves is that because this program cannot be done by government alone, it requires a very strong community-led intervention. Yeah. It requires a reach-out program. So we need to begin thinking, what frameworks are we going to put in place for government to actually fund community outreaches? Because we do not expect donors to continue funding that aspect. So that is number one. And I think that is very, very key for this program to succeed. Because as Dr. Shikeli said, it's not like a prescription base, it's a screening base. There is reintegration, there's also peer education. There's a lot that involves by the time you bring this person to come and accept that I need help within the facility. The other element is that I think is what we have just brought out. So now I was a lawyer, I used drugs, and I lost my job. Now you've given me treatment, I want to work. So which law firm is going to take me? So that's now the next challenge. How do we then sustain this person you've already helped to come out of drug use, and then now make sure that they don't retrogress, because otherwise they relapse if we do not have a program that sustains them. And that is where I think for me, as Dr. Shikeli said, in addition to government opportunities that exist that we must look at and bring them to the table, including the youth funds and all these other kind of funds we have, we also need to think about the private sector. Because the private sector has a very unique way of doing things. They can come in and support us to say that you have a cohort of 8,000 people who are actually people not useful to the society. Now these are people who now are ready to come back and reintegrate and do something useful with their lives. How can then we quickly as a society take them in and embrace them and therefore give them opportunities to work? And most of them are brilliant people, those who have worked with most of the people who inject drugs who have recovered. They're really brilliant people, and when they start working, they can give back to this country and they can be productive people. Thank you.
I'll open the floor for a bit of questions and comments from our audience here in just a bit. If you have any burning comments, we'll come to you as we sanitize the microphone to move it around. But Dr. Kate, explain to me what the MAT program is, and is this the silver bullet?
Not really, because it is a combination of several intervention strategies to be able to see how we can sort out the people who inject drugs.
Yeah.
MAT program is medically assisted therapy, whereby in the 9 counties the services are being offered. Clients who want to stop taking the drugs go in and take methadone, to be able to reduce the urge to take the drugs. And it's provided for free, but it can also be abused as well. That's why it is restricted. In fact, when it is supplied to the BICEMSA, for it to be transported to the different sites in the country, it has to be escorted through the law enforcement.
Yeah.
And so most of the clients who, after some time, the doses are tapered for each client to ensure that according to how much the person can be able, like how far were they, and then as you go along, as you are tapering off, some are able to completely, maybe move to another, you call it ibuprofen that you use.
Yeah.
And you combine methadone, MAT therapy, and that is medical assisted therapy, with other services to rehabilitate this person.
Okay.
And I am really glad, for example, at the moment, as Dr. Shikeri has said, whereby the counties have come in to be able to work together with the national government and even want to take over and be able to work with the private and the other institutions to ensure that it continues, because as we talk currently, it's more funded by donors.
Okay.
However, when you look into the intervention, it has worked, I would say, magic, because in reduction of criminalization of those clients, if you go to engage some of the clients who have gone through the program, they have been able to stop the use of the drugs and be able to be rehabilitated back to the society, take over their jobs. It may not be silver bullet, but we are almost there.
It is a step in the right direction.
Yes.
All right. Agnes, what do you think from the National Police Service direction is the best strategy to deal with this issue? What do you think are the gaps, and what is the best way going forward?
Thank you, Trevor. Now, for me as a person, as Agnes, I tend to feel like we are actually punishing poverty. Because when you look at the drug users that we actually take to prison are actually the low-level drug users. Who is taking care of the high-end drug users? Who is arresting the high-end drug user? By the end of the day, they are all users. By the end of the day, the user is still in conflict with the law, despite these are the lower level users. And I'm sure the lower level user is what MEWA and Reach Out are dealing with. The lower user is what the methadone clinic is all about. So when you look at these aspects, we really don't know where to strike the balance. Because by the end of the day, we are saying, yes, drug use is still criminal. And in as much as we are actually encouraging law enforcers to stop discriminating and stigmatizing and to embrace that these are sick people, we are not asking them to contravene the law. And we are saying, yes, the user is still in conflict with the law. Yes.
All right. And Hussein, I'd like to come to you on this. I see there's a lot of feedback here from one Henry Mbugwa, says the controversial providing of syringes and needles, since they are going to inject themselves anyways, yet not wanting to encourage drug use or simultaneously giving the alternative. Should there be a provision of syringes, so to speak? Because this is what Henry Mbugwa is suggesting here, because he says that they are going to abuse this substance anyway, so just give them the syringes.
Actually, part of the recommendation that we had put into this memorandum, this is a memorandum that the caucus of service providers from Mombasa, Nairobi, Kwale, and Lamu have put up. It was sent to the Parliamentary Departmental Committee on Administration and National Security. This is the committee that was actually handling the Amendment Bill 2020. So in that, one of the recommendations that we had put in is allowance of the paraphernalias that were actually the CSOs are giving out, the needles and syringes. Because once this becomes a law, and we are urging the president of the country to put a hold, at least temporarily, on this. They should be returned back to experts, should be returned back to the parliament for amendments, so that before it becomes a law, those issues of contentious issues are actually handled. So part of this is we recommended the use of paraphernalias. Outreach workers who will be going to the streets giving out the syringes should not be arrested, so they should be defined. That is why we are working very close with NASCOP and NAC. These are government agencies that are, plus the Department of Health, are working with the CSOs. We are the frontliners in this fight. Without the work that we people have been doing through the years, about 20 years, Mr. Taib, for the last 20 years, the CSOs have been on the ground working with people who use drugs. Right now, we have incorporated the harm reduction intervention. Initially, when we started, we were looking for supply reduction, supply for the police. What was happening during the early days was the demand reduction, and it was noted that we could not stop the use of drugs. More and more people are taking up drugs, so that's why we adopted WHO, UNODC, UNAIDS technical guidelines on harm reduction, as Taib rightly put it up. It's about 9 interventions, from HIV prevention, testing, TB, hepatitis, a long list of things that we have been working, and NAC and NASCOP and Mombasa County came on board. Initially, we were doing this the hard way. Before the after we approved, there was a lot of interrelation between drugs and HIV. That's when we started getting funding and the government came on board. So the CSO has been in existence all this time, and as rightly put by Madam, we need to be supported. The donor funding is not fast disappearing. There's no more donor funding. The county government should take up the program. I'm urging the members of parliament through the CDF kit. They should put up rehabilitation centers throughout the country. The way they are putting up police station and chief's offices. This is where we need to move. People are saying Coast Mombasa is suffering. The drug abuse now has no boundary. We are seeing a lot of drugs coming from Ethiopia. So it's a big problem. It's no longer the problem of Mombasa people. Mombasa people have got their share, but the rest of the country is coming up. And Madam, the issue of Mogoka is really eating up our heads. We have been talking to Nakada, we've been talking, shouting it aloud, but nobody's listening. A bigger percentage of those coming to our rehabilitation centers, and more than 90% of the youth who are actually coming for rehabilitation services are from using Mogoka, are mentally, they've got mental issues. This is a big problem for this country, and if we don't act now, it's a big mess coming soon. Thank you.
By a show of hands, how many people have a burning comment or question before I take closing remarks? There's a question over there. Can I get the microphone to him, and then I'll come to you, Taib. Yes, go ahead. Start with your name.
My point is the political goodwill, because in Mombasa, like the case in Mombasa, we had a MAT center, which a member of the county assembly was proposing that it be moved away from that locality. So you tend to wonder, as a leader of a community, how do you tend to push a service that is needed by a larger community? Because if we will have the will to work together as a team, because they are the people in authority. And I'm wondering, At what point in time did the CIDP recognize that drugs is a problem in Mombasa and they need to factor, and when they come down to the annual development plans, the department concerned should have specifics to do with the drug issues?
Yeah.
Thank you.
All right. Yes. Go ahead.
Yeah, thank you very much. I think that's a very good question. First is, I mentioned about the political goodwill.
Yeah.
We really need to have that movement and momentum. Of course, we had a setback within our MAT program, but what we did is this, the question that you asked. We involved the community themselves, people who live there. How best can they be able to be key informants in terms of changing the narrative of drug users? Because if we cannot accept the facility to be in our community, where do we want it to get it? We want to get it in prison, or you wanted to get it outside the border of Kenya? No, we want it to be a community intervention. That's why it's kept within the community. Of course, there were challenges within the school, the interventions that were there within the clinics. We really need to sit down and talk about it, and that's why we had that political goodwill at the county level to be able to factor in the possibilities of having that, and of course, the question of county integrated plan. I think when we started 2013, we raised our issues, and Dr. Shikeli was there, and it is there, and that's why the methadone clinics, the ones that are managed within the county, it is from that kitty and that plan, and we are not losing hope, because it started small and we are going at phases in terms of how they can be able to be initiated in all. I think by the end of this year we'll have in each sub-county a methadone clinic, and that will be a unique in Mombasa County, where within every sub-county we have a service that is led by counties, supported by national through NASCOP and NAC, and also integrated within the structural intervention that is giving us a support within the law. So we are looking forward to have that greater partnership, and also how best can we be able to see the programs going on. We appreciate now we have the needle and syringe program, which is a government-led intervention, which is approved, it is an evidence-based intervention, and we are implementing it within Mombasa and other counties that Dr. has mentioned, which is working well. And we have seen the reduction of HIV amongst people who are injecting. It was worse. It was 50% of those we are testing, 50% were HIV positive. But now it's reducing. It's going to 18, 16 in different counties. It's going down to 5 and what. And this is because of that commodity, the needle and syringe. I know people will find it very harsh in terms of we are increasing the number of people using, but you're not going to give any Tom, Dick and Harry a syringe for those who are in program. We have worked here for 20 years, so we know. We live with our brothers and sisters who are drug users. We have enrolled them into different programs, and that's why you have enrolled them or initiated them with needle and syringe program.
All right. I see the microphone is over there, and that's the last question or comment I will take, because we can't move the microphone around too much. Go ahead, start with your name.
Okay, I really appreciate this discussion, but I really want to speak about sex workers, because you realize that sex workers are twice stigmatized, and you find that here in Mombasa we don't have a model where sex workers can run for these services. We were just thinking, because we have NASCOP here and we have NAC here, we are thinking that these are policy makers. Why can't we have a model where the sex workers can also go and have these services without stigma, without shying away from these services? Because we realize that now that during this COVID-19, they were having they experienced a lot of stigma and a lot of violence that was going through their daily activities. And you should realize that a sex worker is a parent. Some of them share their houses with their children, and when they start abusing drugs, they also introducing this to their own children. What is it that you are putting in place so that we can support this sex worker who is a parent, who has children, and reduce the number of those sex workers who will make sure, who will integrate their children also in drug abuse? Because during COVID-19, because of the closure of all these hotspots, most of the sex workers started practicing their sex work from their houses. And then you realize that most of their children didn't know about all these things. You realize that some of their children have started abusing drugs at this small age, between 9 years to even 14 years, to that age, because the stigma is just too high. So I was just thinking, is there a way? Is there a possibility? Because we know that Global Fund is here with us, and Global Fund is funding drug issues. Why can't we have a model for sex workers in Mombasa?
Dr. Kate and Ruth, I will let you respond to that directly. You have a comment or question? Yes, go ahead. Start with your name.
Kwa majina naitwa Zainab Juma.
Yes.
Mimi ni mkazi wa Majengo Kingorani.
Okay.
Na nimesoma hadi darasa la 7. Hatimaye sikufanikiwa kumaliza shule, niliingia katika mihadarati. Bangi, pombe, unga, nilivuta hadi glue. Na hivi mpaka sasa nina mtoto wa miaka 4. Na mimi mwenyewe nina miaka 9. Mimi sasa hivi mnavyoniona sikuwa hivi. Nashukuru sana shirika la MEWA. Limenisaidia sana. Na hapa pongezi sana.
Asante.
Sasa na chenye mimi nilikuwa nataka kuambia. Kuko nje kuna watu wanataabika, watoto wadogo kama sisi. Na ningewapenda muwasaidie.
Ungetaka tufanye nini haswa, usaidizi upi ambao mnahitaji kabisa?
Kwa kama sisi waraibu ambayo tuliojinasua kama mimi sasa niko female shelter MEWA. Na nimekaa hapo kwa miezi 11. Na sisi kutoka pale, yani siku zangu za kutoka zimefika, lakini siwezi kutoka, naogopa. Maana nikitoka pale nje naogopa naweza rejelea tena uraibu. Na naogopa sana kwa sababu gani? Sina kazi, I'm still young. Na upande wa baba pia naye ni mraibu. Mama na baba walitengana, na mama anaishi kivyake, baba naye ni mraibu. Sasa na familia yenyewe ni hivyo. Sasa ningependa nyinyi kama wa serikali mtusaidie sisi.
Okay. Asante.
Sio mimi tu peke yake. Hata wale wa kule nje wanataabika.
Okay.
Na ningependa sana kushukuru shirika la MEWA, limenisaidia bila malipo. Na nimekaa pale 11, I think I told you, 11 months. Nashukuru sana.
Asante sana. And Dr. Shikeli, you know, now this is a practical example of what we were talking about earlier on, So they've been integrated, she's rehabilitated when she's even scared of leaving. And pongezi, by the way, I think it's very courageous of you to have that conversation with us and to tell us live on air. But what then now are the immediate interventions for her?
Well, and this is what I was talking about. And really that it is a multi-agency approach, and especially women. I think Dr. Ruth also talked about it, Dr. Ruth Masha, that women have special needs. They have, like now, for her, she needs a shelter. She cannot go back. But then what? She needs to have a job. She needs to look forward to fend for herself. Her father is also an addict. So if she goes back to the same environment, she will definitely not get out of it. So really, and that's why we are saying we need the private sector to really come up and assist us. We cannot do it alone. But I think we need also more shelters, because the shelter at MEWA is very small. We have so many more. And maybe just to say that out of the 1,480 clients that we have on methadone under the MAT program, that is, we have 13% are females. And that's the largest number of females in a MAT program in the country. But it is also, we have not reached all of them. But I'm very happy that the women are actually coming.
Abdurrahman, you wanted to jump onto this?
I think the remedy to this is the involvement and reintegration back to the community. What can we be able to design training so that they can be able to go back? We have started in our own little way, MEWA and Reach Out, to give livelihoods training, but because of shortage of funding and also reintegrating back to the community, this kitty couldn't do much. And also within the COVID pandemic, we started a poultry farming which died because we couldn't have sustainability in terms of that. But I believe if we can have hands-on in terms of training, giving them opportunity to practice and also go back, like the example that you was given here. If he's a lawyer, how can he go back? So how can we be able to have moot session employment exercises so that they can be able to reintegrate, go back outside there, engage halfway house program to be able to engage, come back and share their challenges. But I believe with the sustainability plan that county has developed with us, it will be also one of the bullets that we are talking about, because it has a comprehensive, it has pillars that in terms of provision of service, prevention, in terms of reintegration, and also to have to sieve those who have gone graduates, those who are not, didn't go to school. How can we be able, because we don't have one size fit all. It has to be tailor-made according to the needs and the time of the need that is needed.
Okay. There's one more comment there, then I'll come to you, Dr. Shikeli.
Okay.
Yes. Go ahead. It's okay.
I just wanted to add, in fact, the center, NACADA Center in Miritini, that we work together with, we've been working with Ministry of Health, NAC, Ministry of Youth and Gender, and Ministry of Education. We've come up with, and of course the county government of Mombasa, they've even come up with a curriculum for training, apprenticeship programs for those who are stable. We've actually done an analysis of all our, the 1,400, we took, the first 100 clients that were stable, and we looked at their education status and all that, and we actually gave them to NACADA for them to start off this program.
All right.
Thank you.
As we close up on this, then I'll come to you for final remarks on this conversation.
Thank you so much. This discussion is good and very fruitful indeed. My question goes to the national government, that is to NAC, both NAC and NASCOP, and also to the county government. Previously, we used to have funding of the community-based organizations, whereby people like the young lady could, after rehabilitation, that is, they could be incorporated to the community-based organizations, whereby they could be assisted. But that funding is no longer there. So my question is, what strategies are there to ensure that such funding comes back to the community-based organizations, so that that funding could help groups at the community level to implement activities which will help our young people to be able to come up back to the community after rehabilitation.
All right.
Thank you.
Dr. Ruth, I'll start with you, and that will form part of your closing remarks as well. And you've heard what she's mentioned. You can just go ahead and start from either him or her and make your closing remarks as well.
Thank you very much, Trevor. Indeed, I really admire her courage, and thank you for sharing your story, which is really encouraging for many other girls like you who probably are currently using drugs and they would like to seek for help and they know where they can get it, especially here in Mombasa. I do acknowledge the challenge, and the challenge has been brought out very rightly by the previous speaker who has said that we used to have funding. But I think as a country, we have to move forward by thinking differently. We have had funding for HIV through donors for many, many years. It is 40 years into the epidemic. Donors are on an exit mode. So we cannot let people like her go unattended because we cannot come up with ways to fund communities. Because government cannot do it all. Dr. Shikeli has been saying here, it's a multiple stakeholders. So even as a government, we must find a way to fund communities. We must look into the frameworks that deter us from being able to pass money into community-led organization and begin creating those particular frameworks. For us at the National AIDS Control Council, that is the conversation we are currently having. We are asking ourselves, yes, you have all these rules the government has, but our program is only effective if we fund community-led organization. So we must look at, yes, there's procurement, there's all these acts of management of public funds, but at the same time, we need to start saying and working with Parliament that has been so supportive, saying, how can we then create new rules? Because these rules are created by us, these laws are created by us that allow us then to fund those kind of works that he's talking about, community-led interventions that can come in where government is not able to do such interventions. Thank you very much.
Dr. Kate, closing remarks as well.
Yes, thank you. Thank you, Trevor. It has, this session has really opened our eyes, and thank you very much for sharing your story. Honestly, it's very encouraging, and I'm glad that Dr. Shikeri and has really shown ways that they can come in and be able to have to assist, knowing that she's a young girl, she has a baby, and is really looking forward. I can see that part of self-driven, that I want to stop it. That's why I do not want to go back.
Yeah.
I think for all of us is to take a step back. Where did the rain start beating us? And for us to stop many young girls and boys being initiated into the illicit drug use, what do we need to do? I know many are experimenting, others is because of peer pressure. So I think it's an area that we need to educate our young ones, but as well that part of addressing the bigger problem of access to the drugs. But I'm hoping that, as well as what Dr. Marshall said, that not only the country but the national government be able to put in funds to be able to address the problem of people who inject drugs, and even the ones who do not inject drugs. As you have said, that Mogoka is also becoming a problem in the country. And when we are able to put in that coin and be able to, the many programs that are there, integrate the services of people who inject drugs, then we'll address the problem. And I hope that this conversation will not end here, that it will be the starting point for us as a country, be able to discuss it at not only at the national level, at the county level, and even into the different sectors. And I love the part of the different, the law enforcement, the Ministry of Health, the county government that have come together to see how do we address this. We need more to come in. And when we come in, that concerted effort, then we'll be able to address the problem we have. Thank you.
Agnes, closing remarks?
Thank you, Trevor. Her story is very inspiring, and now it brings me to the point of women users who are actually arrested with babies, young babies. And the babies are not in conflict with the law. So we really need, as a country, to support and strengthen the child protection units, so that when they are actually taken in by the police, the children too should be taken care of, not as remandees, but as children who need care and protection. And then to go back to his point of the community, there's a very thin line between poverty and insecurity. A very thin line between poverty and disease. And this is a mental health challenge. It is a disease. But we have these platforms. When you come to communities, we have platforms created through the National Police Service. We have the community policing platforms. We have the Nyumba Kumi initiatives. How well are we utilizing these platforms and initiatives to ensure that we reach out to our communities? How well are we sensitizing our communities? Yes, we are sensitizing the healthcare workers. We are sensitizing the law enforcers. But how well are we reaching out to our communities and actually bringing on board law enforcement to tell them, yes, this is what the law says. And the law will not back you up as a user, because this is what the law says. But the platform is there. Are you able to reach out to your communities and come up with those homegrown solutions? Because yes, it is a problem. We need to nip the bud before it actually,
All right, type. Closing remarks.
This has been very productive. My way forward is how best can we be able to take this conversation to the next level? Because we need to look into the legal environment. How best can we be able? It's not supportive in terms of law or incarceration. How do we work with a framework that can be able to give us gains in terms of...
Hold on one second. Let me switch for you that microphone for your closing remarks. Just take the other one. Yes, go ahead.
How best can we be able to work together as multi-agencies in terms of fighting these matters? And how can we be able to draw that thin line in terms of support, having frameworks, having standard operating procedures that can support us. As much as we're waiting for law to change, but currently there are people who are injecting. There are people who are sharing needles. How can we be able to have that factor in terms of creating an enabling environment? Second is how best can we be able to remove that notion of insanity, doing the same thing every time and expecting a different result. We are so tired of having dictated of donors that are giving us, this is what you support. We know our needs. We are living in this society and we know where it has trained us. We don't need to go back. We know the reality. We don't need to go back to the community and the world. The community is crying for help. Needs this help like yesterday, not today. We need to reverse our area. We need to look into our intervention that we're using. And lastly, change the narrative. The narrative of drug use. I think menace has been highlighted to Mombasa. It has been highlighted to the coastal region, but you're not getting that support, the technical support. And we have people who are born and bred here who can be able to fight in this menace and contribute to the country in a bigger way. We need to have that space.
Do you have the other microphone on the other side? That one? Let me have that one. Let's give it to Sain for closing remarks very briefly.
On my side, first of all, I thank the organizers of this gathering. It's quite constructive, and as Taib has put it, my take is for multi-agency, multi-sectoral collaboration and partnership. This is where we've been failing. This problem has to be tackled by each one of us. We should come together and make sure that we work as a team. That's when we can actually be able to succeed. We don't have to go out of the country to see for evidence-based practices. We have enough here in Mombasa. People from all over the world have been coming to see the achievement we have had. We have made through issues of harm reduction, working with people who use drugs. I call upon you all to see this young girl, whatever she has been telling us, many more are suffering. The women's are really suffering with their children, and the list is, and I'm calling for the Minister for Interior. Some 2-3 years ago, we were part of the review of the National Drug Policy. The first one of its kind. We are yet to see this being signed and come into force. Had this been ready by now, these amendments will not have been put this way, because we were part of the team that were in the review team, and we're still waiting for that. So we are calling upon the President of the country to make sure this amendment bill has to be adjusted to suit what we've just discussed here. Secondly, the National Drug Policy has to come into force. It has to be signed so that it can guide us to see how we can move as a country forward. Thank you.
Adija?
Thank you very much. For me, Trevor, I think everything has been said, but one thing that is... I
think your microphone is off. Try.
Okay, thank you, Trevor. First, let me say thank you to Zainab. We have heard you, and I know it's not only in Mombasa that we have Zainab. I'm sure there are many more all over the country, the same. And we must work towards...
Unfortunately, your microphone seems to be having a bit of challenges. Switch with that other one.
So we have many more people like Zainab suffering.
Yeah.
I think it is time that we do have, we've been talking about domestic financing. I know everything else has been talked about.
Yeah.
We need the private sector to come and join in. We have said this is a multi-agency fight, or we have to work together. We are not seeing private sector coming in. Really, for me, is a big request, a humble request to the private sector to come forward and really work with us so that we can save young girls and young boys like Zainab and others.
Yeah.
Thank you very
much. All right. I think pass the microphone to her. Kidogo ningependa utoe ujumbe kwa vijana kama wewe ambao pia wanapitia masaibu kama hiyo yako. Ungewaambia nini? Mwito wako ni upi kwao? Sababu story yako ni ile ya kugusa sana, lakini iwapo wewe umemanage kupita na umetokea hiyo side nyingine vile unasema, au vijana wenzako ambao pia wana hizo tashwishwi hapa na pale, ungewaambia nini? Weka microphone karibu na mdomo.
Chenye mimi ningependa kuambia
wewe uliweza vipi kutoka hiyo upande mwingine? Ni maombi, ni usaidizi upi ambao ulipata? Mtu ambaye akuna shida kama hizo zako saizi anafikiria sasa mimi nianze wapi, ungemwambia anzie wapi?
Mimi niliamua mwenyewe. I'm tired. Nilivyoamua mwenyewe nilienda Mewa Hospital. Pale nikapatana na watu wakanielekeza na wakaniambia watanihudumikia na nilifurahi sana. Na mimi toka hiyo siku sijawahi tumia kitu. Na nashukuru Mungu Mewa walinikubali bila malipo. Maana mimi hali yangu ilikuwa ya mbaya kusema vibaya. Yaani ingezidi sana ningekuwa sasa niko na virusi za ukimwi ama ningekuwa niko na hepatitis ama nimekuwa sex workers.
Kwa hivyo inaanza na wewe mwenyewe mwanzo useme umechoka alafu utafute usaidizi. Ni mimi mwenyewe nitafute usaidizi. Yaani tuseme uraibu ni wewe mwenyewe kuamua. Ukiamua utasaidika, yani tuseme utasaidika. Thank you so much. I think your story is very encouraging. I appreciate that. And thank you all for making time for this conversation. It's been an absolutely uplifting conversation and an eye-opener for that sake. Dr. Ruth Laibon Masha, CEO, National AIDS Control Council, thank you for making time. Dr. Kate Ngugi, Head NASCOP, asante sana. Dr. Adija Shikeli, Chief Officer, Medical Services, Department of Health, Mombasa County Government, thank you for hosting us this evening in as much as your county is really cold. Then Hussein Taib, Mewa, Community Service Provision, thank you so much for making time. Ms. Agnes Irungu, Program Officer, National Police Service, and also Taib Abdurrahman, Reach Out, Community Service Provision. Thank you so much, and thank you all for making time and speaking to us on the Monday Report Town Hall session. And special thanks to the entire team that made this possible. It takes an entire village, I tell you, to put this together, and so many things sometimes go south, but they make sure that everything works out. My name is Trevor Mbija. It's been an absolute pleasure being with you here. Good night. Now yourselves a great week ahead. See you again in Nairobi. See you tomorrow. Good night.